Gastroenterology, College Bollywood. The speaker was introduced to the gathering by the secretary and Dr. Pradhan spoke on the topic management of hilar biliary obstruction. The intricacies in hilar anatomy and procedures, including anatomic and non-anatomic liver resections, were duly elaborated by the speaker. A healthy discussion followed. No particular association matters were taken up for discussion. The meeting concluded for dinner and fellowship at 9:30. So, gives me immense pleasure to introduce to this gathering my senior and friend Dr. Mahesh Bhat, consultant neurosurgeon, Aston Kannur. He did his MBBS from KIMS Hubli, after which he went on to do his MS and MCH from Government Medical College, Kozhikode. After MCH, he pursued a fellowship in pediatric neurosurgery from Wadia Hospital, Mumbai. Then he went on to pursue another fellowship in pediatric neurosurgery from Birmingham Hospital in UK. After which he has joined Aston and is a very strong upcoming name in the field of neurosurgery. We welcome you, Dr. Mahesh, to this gathering. And as you would like to delay the further proceedings, the stage is yours, notification.
Hello. Hello. At the outset, I'd like to thank Suresh sir and Sham and Surgeons Club Kannur for inviting me to deliver this talk. So the topic that I selected today is endoscopic spine surgery, because it is the spine problems are pretty common. So I straight away start with the talk itself. So probably in our lifetime, more than 90% of the people would have suffered from backache at one point or the other. Hello? Hello? Height so it is said that up to 80 to 90% of people in their lifetime, at least once they would have suffered from low backache. But fortunately, most of this low back pain is self-limiting and people recover from it. But only 1 to 2% of the people who have lumbar disc, will have proper disc disease itself. The others will be mainly because of the sprain or some facetal hypertrophy, or it may be even due to some ligamental stretching, which subsides by itself. But the problem is, because it is so common and the population usually affected is 30 plus. So I don't say that it occurs only in 30 to 60 age group, but all people over 30, and most of, obviously, with the working age, a huge number of working age population in our country. So when it affects the working age population, it affects the whole family as such. So it needs to be addressed properly and proper management has to be done. As I said, 90% of all the low back pains can be managed conservatively. It's only 10% who need some sort of even medical management or even intervention. Up to 50% of this 10% who of the most of the who come under in this 10% usually have recurring symptoms. So when a patient comes to the OP, walks inside the OP with a history of low back pain, it is very important to identify what type of back pain he is having. So there are three types of, usually it is classified into three types. So axial pain or mechanical pain. So it is localized to low back area, subsides by rest, and increases on sitting up or sometimes doing work or any bending forward, all those things. And it is more in the evenings, because after whole day of work or something, this pain exacerbates in the evening. Second type of pain is radicular pain. So this I don't need to explain much. It is self-explanatory. This happens when there is compression on the nerve root. So this is very specific kind of pain. Both radicular pain and claudication are very specific kind of pains. Radicular pain happens when there is compression on the nerve root. So the pain radiates along according to the dermatomal distribution. The pain radiates into the leg, either upper thigh, lower, to the leg, or even to the foot. So I'm not going to details of that because that will take more time. And it can be accompanied with numbness, sensory symptoms as well as sometimes the patients will have weakness of the foot or the EHL. And the third type of pain is claudication. I'm not going to details about claudication. You surgeons will know better about claudication than me. Differentiation between neurogenic and vascular claudication. In neurogenic claudication specifically happens when there is spinal canal stenosis. So when there is spinal canal stenosis due to any cause, it may be due to ligamentum hypertrophy, it may be due to the disc bulge, chronic disc bulge, or diffuse disc bulge, or it can be due to facetal hypertrophy. So, or it may be due to combination of any of these. So normal spinal canal diameter in the lumbar spine is around 10 to 12 meter. So when it is less than 8 millimeter, patients start becoming symptomatic. And when it is less than 7 millimeter, when there is severe claudication, then this is a definitive indication for surgery. So as I said, I'm not going to details of the evaluation of the pain. So it is said that there are 12 pain generators in the lower back area. So the most common is the disc itself or the covering of the disc, that is the annulus. These are the three most common areas where the pain from where the pain happens. So there are other 8 more pain generators like different ligaments, ligamentum flavum, posterior articular ligament, annulus fibrosis, and then the dura itself, the stretching of the dura, muscle. So and when there is end plate changes, the end plates of the bones. So osteopenia, that itself can cause pain. So all these are pain. So it is very important to identify where the pain is originating from. So most of the time, what happens is we are not. Patient is treated in general for backache without identifying where the pain is generating from. So that is when the mistakes happen. That is when even after treatment, even after the surgery or even after some intervention, patient is not relieved of pain. So it is important to identify the pain generator. So coming to the disc disease as such. So I'll discuss this first. So there are 4 different stages where the disc disease happens. Initial stage is disc degeneration. Then when it is contained, it is bulging, but it is contained within the annulus. It is called as disc prolapse, disc extrusion. And then when the disc fragments, it is detached from the nucleus pulposus and it is hanging down, it is called as sequestration or migration. So extrusion and sequestration are usually definitive indication for surgery. Disc degeneration is not an indication for surgery. And then when there is prolapse, if it is in the lateral foraminal area, even if it is contained within the annulus, if it is compressing the nerve root significantly, and if it is not relieved by medication for 2 to 4 weeks, then again it's an indication for surgery. So I'll come to details again later. And when the disc prolapse or disc extrusion happens, so again it is we divide it by the area. So whether it is a central, paracentral, foraminal, or extraforaminal. So foraminal, as I said, the foraminal disc, the FZ area, foraminal disc, the foramen is very small. So in that area, even if there is a slight disc bulge, it will compress the exiting nerve root and cause pain. So, as I said, 90% of the patients with low back pain can be managed with conservative management. Usually 2 to 4 weeks of good analgesia and rest would subside. Any sprain or any ligament stretching, all these things usually subside with medical management. So when do we intervene? When a patients come to OPD with definitive focal neurological deficits or bladder involvement, that is an indication, definitive indication for surgery. And as I said, claudication is suggestive of the canal stenosis, which cannot be managed medically. So again, that is an indication for surgery. Then, as I said, extruded or migrated disc, large central disc herniation in the L4, 5, L5, S1 area, even though especially the large central discs, the main risk with this is, if we leave it alone and we try medical management, a patient can develop sudden, urinary retention, the cauda equina syndrome, and then it becomes a surgical emergency. So if there is a large extruded central disc, that is also a definitive indication. Better to do the surgery than leaving alone. And then failure of medical management is a relative, term, because the failure of medical management, proper definition is still evolving. So usually say that 2 to 4 weeks of medical management, if the patient is not pain is not controlled, if there is no what we say is the pain score, visual analog scale score, if there is not if the pain reduction is less than 50% in 2 to 4 weeks of medical management, then again it's an indication for not surgery, any kind of intervention as such. Then when there is instability may be due to degenerative listhesis itself, or it can be spondylosis and listhesis. So when there is dynamic instability, that is also an indication for fusion. So without further discussions, I do with the case presentations itself. So let's directly go to a first case. So first case is a 32-year-old female who had low back pain since 3 months. She was managed medically for 3 months, but it was not controlled with medical management, and she developed severe left-sided radicular pain for the last 1 month, and she had a score of 8. There were no deficits as such. So this was her imaging. Here you can see that the disc, there is a significant disc bulge in the paracentral foraminal area. So it is we cannot directly distinguish into one area, but this is extending from the paracentral to the or the lateral recess to the foraminal area, it is the medical management has failed. So that is why this patient was suggested surgery. So if we say surgery, what surgery to? Conventionally, we would have done is a microdiscectomy, open microdiscectomy. So this is what microdiscectomy is, wherein we put a 4 to 6 centimeter incision, and then retract the paraspinal muscles, and then sometimes we may have to do in an obese patient, we may have to do laminectomy as well, or else we have to do laminectomy, and then we go inside and remove the disc. So here, if you identify, there is a significant, the incision is large, around 4 to 6 centimeter incision, and then muscle has to be retracted, and that will cause severe muscle spasms, muscle damage. And then the bone, which is not pathological, which is a normal bone, that has to be removed, and only then you are able to go to the pathologic area. And especially in this case, in a foraminal or lateral recess stenosis, disc, what happens is when you remove the bone, if you have to take out the lateral, if you have to go to the foramen, you have to sacrifice significant amount of facet joint as well. So facet joint, if you remove in the first go to do the discectomy, if you remove more than 50% of the facet joint, that itself will cause instability later on, and patient may have progressive disease and will need fixation at a later date. To minimize the incision and to minimize the trauma, a tubular retractor or MIS discectomy was later propagated. But the problem with this is, again, even though it's a 2 centimeter, 2.5 centimeter incision and the tubular retractor is placed inside, there is significant muscle damage. And also the field, once we go, it's, the field, when we use the microscope, especially in a 2.5 centimeter, tube, the visibility is very poor. So when you see through the microscope, what happens is, within the 2 centimeter, diameter, you have to pass your suction, you have to pass the instrument, and you have to see inside. So the visibility is very poor, and that resulted in advertent neurological damage. And also, even here, we cannot minimize the drilling of the bone. So that is why the ideal at this point of time, I would say, would be endoscopy. So I don't need to, describe much about endoscopy. So the field of vision, I'm just showing the field of vision in endoscope. This is just a representative image, but especially with the 15-degree or 25-degree scope that we have, the visibility inside the spinal canal is around 270 degrees. Whereas with the open view, it will be less than 70 degrees with the microscope. So what are the advantages of endoscopy over the microdiscectomy? We minimize the collateral damage. That is the most important thing. So the muscles, ligaments, bone, facet joint, all these, we have to sacrifice when you do an open surgery, can be completely, in a transforaminal, I'll describe two types of endoscopy later, but in a transforaminal, we are not encountering any of these structures at all. We directly go on to the pathologic area. Whereas in interlaminar discectomy, we need to pass only a 7-8 millimeter scope inside. So that is the opening in the bone that we need. So we don't need to remove more bone. Whereas in microdiscectomy, patient need usually 3 to 6 days of minimum 3 days of admission is needed. Whereas endoscopic discectomy can be done as a daycare procedure. Microdiscectomy is done always under GA, whereas endoscopic discectomy in a cooperative patient can be done even under local anesthesia. Okay, incision is, as I said, the sheath of the endoscope is 8 millimeter. So that is the incision that we need. 8 millimeter incision is more than sufficient for endoscopic discectomy, whereas in open discectomy we need at least 6 centimeter of incision. So as I said, in obese patients, exposure, everything will become very difficult in a open case, whereas there is no added difficulty in endoscopy. And because there is no collateral damage in endoscopic discectomy, the recovery is dramatic, very quick. In the post-operatively, the same day or the next day, patient is able to walk and go out. As I said, in tubular discectomy or microdiscectomy, the field is filled with blood. Whereas in endoscopy, we use water, saline as irrigation. So we have a very clear vision. Field of vision, I have already told. And the only two disadvantages is, one is the learning curve with the endoscopy, that we have to learn the hand-eye coordination and endoscopic, the tissue holding, all those things. And also it's a 2D vision as compared to the microscopy, where there is a 3D vision. So this is the full scope of endoscopy. This is how the endoscopic spine surgery is classified. So the common ones, I'll say, the lumbar spine that we do is, as I said, there are two types of endoscopy that we do: transforaminal and interlaminar. I'll come into details further in the next slide. So endoscopic discectomies, these are the common ones that we use. And then in case of stenosis, lumbar canal stenosis, we can do a bilateral. It's not a unilateral thing. With a single incision and you going on the one side, we can go above the spinal, the dura into the opposite side, and we can decompress the opposite lateral recess as well as the opposite foramen as well, with a single 8 millimeter incision. These are the three kinds of common lumbar decompression that we do. Then the most common, the other one that comes is the fusion, endoscopic assisted surgery. So the fusion techniques, especially the T-leaf or the O-leaf, when we do, the incision is quite large and the muscle retraction is much more, because we have to go up till the facet to insert the screws. Whereas with the endoscopic assistance, we can do it with multiple small incisions without retraction of any muscles. Then comes the cervical spine. cervical spine, anterior cervical, because of the anatomy and because of the major structures, trachea, esophagus, and the major vessels, they are trying the anterior cervical discectomies, but still it is not widely accepted. But the posterior cervical, foraminotomy and discectomy in a particularly selected patient is very beneficial. We can completely avoid the fusion instrumentation in those cases. So this is the what I said. This is the difference between the transforaminal and the interlaminar endoscopic discectomies. So in transforaminal, as I said, interlaminar is usual. The anatomy is the same. We go from the midline back, go in the interspinous or the interspinous space, interlaminar space. Usually L5S1 disc. L5S1 interlaminar area is quite big. It is around 1 centimeter. So 8 millimeter scope will go without even doing a foraminotomy. Easily we can pass the scope. Whereas with the L4-5, usually we need to do a few millimeters of laminotomy to get into the spinal canal. Whereas in the transforaminal, it is completely lateral. The incision goes from flank here. So it goes in the muscular plane, dilates the muscle, and in the foramen, it directly reaches the disc area without damaging any normal anatomical structures at all. So this is the instrument. I mean, how our endoscope and the instruments look. There is a sheath of 8 millimeter, and then there is a scope with a camera of 7 millimeter, and it is usually angulated either 15 degrees or 25 degrees. And there is a working channel. For a 7 millimeter scope, there is 4.1 millimeter working channel, and for a 10 millimeter scope, it is 6.3 millimeter working channel. So that is sufficient to remove the pathological area. And whatever the suction is not, usually in open surgery we need two instruments, two-handed instruments to suck the blood. Whereas the saline does the work; it washes away all the blood, and we get a very clear field. So this is a transforaminal, where we land in the safe zone, what is called the Campine's triangle. So in the transforaminal endoscopy, from the flank, when we insert the needle, that is where we land. That is a safe area. That is the exiting nerve root, the lower end plate, and the traversing route. That describes that Campine's triangle. It's not exactly actually a triangle. It's quite kind of trapezoid. It is oblique, but for simplicity, it can be considered as a triangle. So coming to this patient, you see the disc is in the foramen. So if you do a microdiscectomy, you will have to sacrifice the facet joint, and that itself will cause instability. So that is why, and since it's a foraminal disc, it's a lateral disc. That's why I selected a transforaminal approach. So this is the markings. Midline, a patient is made to lie prone, and this is done under local anesthesia. And with the you can see here, there is a epidural analgesia is also given. This is not epidural anesthesia. It is just for analgesia. That's it, epidural analgesia. And if the patient is very cooperative, analgesia is, it can be done even under just local anesthesia itself, local infiltration itself. So midline is marked, and the L5, this is L4-5 disc. So L4-5 disc space is marked both in the AP and the lateral. And then the SP line, the facet line, the spinous process line, and the facet line is marked using the fluoroscopy, CM. So the area in between these two lines, the SP line and the facet line, is a safe area where we can put the needle in without any risk of going into the peritoneal or the retroperitoneal structures. So this is the markings, the midline, AP and lateral, disc space is marked. And then the spinous process line here and the facet line. All these lines are marked, and then the incision is planned. So then once this is done through the 8 millimeter incision in the middle, the 8 millimeter incision is incision is done, and then the needle is inserted. So the needle is inserted such that in the AP view, it should pass the midline of the disc space, whereas in the lateral view, it should be in the upper third of the disc. That is a safe area, and that is where the needle. This is the ideal position where the needle should be for inserting the scope. and over the cave, then the guiding wire is passed, and over that dilator is passed, and dilator is hammered into the disc space, and then the scope sheath is passed. So that is this is the final scope position. That is where you can see we are in the near the midline, we are going up in the midline, and here we are in the foraminal area, just in the upper part. So this is how the scope is placed. This is just a, I didn't have the photo. So this is how the scope will be. This is how the position of the patient, the scope will be. So once the the sheath is placed, then the scope is inserted, and directly you can see this is this is the first pass of the scope. There you can see directly this is the cranial and caudal, and that is a traversing route. That is a nerve route, traversing route that you are seeing. And then once I change the direction of the scope downwards, this is a herniated disc compressing the nerve root. So directly that's disc is removed without damaging any other normal tissue. So discectomy is being done. The loose fragments compressing the nerve root is removed. This is the speed. I have made it as a 2x speed just to speed up because otherwise it will take long time. So that is why that the shaking is seen. And this is with the RF. I am delineating. That is the annular tear. You can see the annular tear here. This is the annular tear through which the disc was herniated. So annular tear is delineated. So now actually the herniated disc is completely removed. And then whatever loose fragments are there, if you don't remove the loose fragments, there is a risk. The high risk of reherniation of those disc contents. That is why loose fragments are also removed. Disc fragments. Okay, so when I retract the nerve root upwards, you can see the anterior thecal sac, and the fat there seen there is actually the epidural space. So in the same way, you can even go till the opposite side. You can even the midline disc can also be removed if it is within the entries. That also can be removed with this approach. So this is the traversing route and this is the exiting route. So both routes are clearly seen, and make sure that both are decompressed. There is no disc compressing any of these. So if we place the needle properly and the scope properly, this is an in and out procedure. This can be completed within 30 minutes. So that is the epidural space that we are seeing. We can see the both end plates on both sides. This is the upper end plate and the lower end plate, and the epidural space. This is the exiting route. This is the incision. As I said, 8mm incision is more than sufficient. We are not, damaging any normal anatomy. It is just dilatation of the. We are just splitting the muscle and passing this scope. That's it. So this is the pre-op. That is the post-op. You can see that and especially in this, we can do, because it is continuously irrigated with saline. The post-operative area is completely clear. We can do a immediate post-op MRI and confirm that disc is gone. So we can see that the disc is completely cleared. And the next post-op day, the pain score was the patient still. Pre-op score was 8. Post-op patient had a 3/10 score, but after on 2 weeks, patient was completely pain-free. So patient was made to walk and discharge the next morning. So as I said, the main advantage is patient is post-operatively completely pain-free. I gave some paracetamol analgesia for 3 days. That's it. Patient didn't complain of any more pain. Generally, we ask them to take rest because there is an annular tear. That annular tear has to heal. Otherwise, if they go for direct activity, there can be recurrence of disc herniation. So that is why we ask them to take rest for at least a month before they go on for activity. But generally, they can do their routine activities from day 2 or day 3 itself. So that was a transforaminal. I'll also give an example for interlaminar endoscopy. So 48-year-old female, again low back pain for 1 month duration. but she developed a severe left-sided pain and numbness for 5 days with a score of 9. So this was the disc. So you can see it's a central disc, central or the paracentral disc, and this is a migrated disc or extruded disc. So here definitely the management would be interlaminar rather than transforaminal, because transforaminal, if you go, whatever this is between these two entities, if it is between those two entities, we can easily go in with the transforaminal. So transforaminal go in this way. But for interlaminar, when it is more than 50% of the vertebral body height is crossed, so then we cannot do transforaminal endoscopy, so which needs interlaminar endoscopy. So this was the problem actually in the endoscopy came in the probably in the mid 2000, 2005, 2006 time, and it was propagated for till 2012, 2013, wherein only transforaminal endoscopy was done first. And during that time, surgeons used to do all disc problems with the transforaminal itself. And when there is a migrated disc like this, if you do a transforaminal endoscopy, you will definitely leave some remnant down. So that was the risk for failure of the surgeries and recurrences. So with the advent of this interlaminar endoscopy was propagated around maybe around after 2015 itself, and first interlaminar endoscopy in India was done only in 2018. So with the interlaminar endoscopy, we have a 360-degree approach endoscopically, and we can tackle any situation. So here anatomy is simple. It is known to everybody. So we put the cannula in, and spinal laminar junction or the facet laminar junction, we place the scope, and then we do endoscopy. So here straightforward, there will be some muscle tissue which is just over the lamina, which we need to just coagulate and remove it. So this is cranial and that is caudal. Okay. And then this is the we can see the lamina, superior lamina, inferior lamina is made out, and in between is the yellow ligament or the interlaminar or the yellow ligament. So as I said, since it is L4-5, that is space is not enough. It is not 8 millimeter. That is why we need to drill a little bit of lamina, but it is hardly 2 or 3 millimeters, not more than that. So endoscopically, the lamina is drilled to pass the scope inside. So eggshell drilling is done, and then the remnant is removed with the punch. So again, this is also in 2x speed. So you can see the nerve root now, the neural elements. So that is the midline. And once that is done, see, you can see the root is bulging, prominent, and it is not free. It is bulging. So gradually the root is lifted up, and a plane is made between the root and the disc. This is the yellow ligament which I am removing now. So there may be some bleeders, especially in the interlaminar, and that can be easily controlled with RF. So once that is done, the scope is, as I said, the sheath is 15 to 25 degree angulated. So the bevel is rotated so as to retract the nerve root. And then what we see is the prolapsed disc or extruded disc that is removed. So there was in this particular case, there was a calcified fragment which has caused a small tear in the dura. But as with open surgery, we need not worry about the dural tears as such, because there is no space for the CSF to come out, because as soon as we remove the sheath, the muscle closes. So there is a very minimal risk of CSF leak. So here you can see the extruded fragment being removed. So there is an extruded disc fragment which is being removed. Okay. So again, here you can see 8 millimeter incision, and this is the post-op MRI done immediate. In the same evening as post-op. You can see that there is the disc herniated disc is completely gone. Patient is completely pain-free the same day after surgery. And this is the same day evening patient is walking and is discharged home. So these are the two basic, endoscopic techniques that I have just shown it to you. Other than that, we can also do other techniques as well. So wherein, as I said, the endo-TLIF, endoscopic assisted interbody fusion can also be done, especially in case of listhesis. When there is instability and listhesis, what we can do is all the four screws. The screws are inserted with a simple 8 mm incision for each screw, and then the interbody cage, this end-plate preparation, disc removal, and the cage insertion can be done through endoscopy without damaging any normal anatomical structures. So here you can see the cage being inserted after insertion of the cage with endoscopic assistance. And this is the incision that we need. Instead of a long, midline incision, which need around 8 cm incision for this particular procedure, what we do is, these are the four incisions are for the four screws, and one lateral 1 cm incision for the scope for the cage to be passed. So other than the endoscopy itself, as I said, it's only less than maybe out of the patients who come with the low back pain, it's only a very small percentage of patients, less than 1% of the patients who need these kind of surgeries. Although around 10% of the patients are symptomatic and they have recurrent symptoms, they may not need surgery always. So we can manage with different kind of other techniques, interventional techniques. That is, either we can give blocks, or newer techniques are coming up that are that is called as radio frequency ablation we can do, and also cooled RF, which I will describe. So this was a particular case. There you can see there is an annular tear here. Yeah. So you can see that this is the annular tear with the fluid here, and there is some facetal hypertrophy as well. But presently, patient presented with the acute exacerbation of pain because of this annular tear. So usually this annular tear, the fluid inside the annulus, that heals with time. You need to give around 3 to 6 months of time, during which time the annulus heals itself and patient is usually pain-free. But during this 6 months period, if the patient is not relieved medically, what we can do is we can give blocks. Especially in this case, since there was a compression on the nerve root. So what we managed to do is we pass the needle as with the transforaminal endoscopy. The needle is passed into the foramen area, and then confirmed with the contrast injection is given. You can see the exiting nerve root there. So this is the exiting nerve root sheath, which is identified with the contrast, and then a steroid injection is given, which gives good 2 to 3 months pain relief for the patient. Same thing can be done for the facet as well, not just for the nerve root. So here, this was an elderly patient who has, here you can see that, the patient has significant testicular hypertrophy, and there is a disc, there is a canal narrowing. So there is a instability. This patient requires fusion. This is an elderly 70-year-old obese female patient, and she was not willing for surgery. But as a pain relief, she had a severe, axial kind of back pain, mainly because of this facetal hypertrophy. So facet block or the medial bundle branch block was given under fluoroscopic guidance, and that again gives relief for 2 to 3 months, significant pain relief. So one more new technique, as I said, RF ablations have been done for the last more than a decade now. Both the medial bundle branch, the facetal RF ablation, as well as the disc ablation was being done. But this is a new technique, the cooled RF technique, wherein the problem with the RF was that single at one, if you pass the needle through one place, and if you pass the RF needs to be there. I mean, we have to pass the RF current for at least 15 minutes for the ablation to happen. So what used to happen is the temperature, we cannot regulate the temperature. So usually they would, the risk was the nerve damage, the neural damage that happens due to thermal injury. So that is why this cooled RF is now being promoted, wherein you pass the two needles into the disc space or the facetal area, and then the temperature between temperature between these is maintained within 60 to 70 degrees with the help of the saline irrigation passing in between these two needles. So that maintains the temperature, and if there is a raise of temperature more than 70 degree, the machine auto shuts. So this gives very significant pain relief. And usually what this is in chronic low back pain, when the pain is due to new nerve terminals that comes. So this ablates all those nerve tissues, and this in a properly selected patients, this is a Medtronic cold RF machine. So they give a guarantee of 2 years pain relief, guarantee of 2 years, because the now generation again will take around more than 2 years. So this is all temporary measure. This is not a permanent measure. This may progress, but this is a good pain relief. So I'll just give an example of the cervical, utility of the endoscopy as well. So this was a patient, 56-year-old male patient who came in with severe left radicular pain. He had severe grade 10 pain. I mean, VAS score was 10. He was saying that he has this pain for the last 1 month. He has not been able to do anything for the last not even slept for last 1 month. That's what he was saying. And you can see the the foraminal disc there. So in the axial also you can see that. That was the foraminal disc which was compressing the nerve root. So here also you can easily do a endoscopic foraminotomy, and even the discectomy can be done. So this was the under GA patient was operated, and this is the foraminotomy that was done. You can see the enlargement of the foramen, and you can see that facet up to as I said, up to 50% of the facet can be drilled, and it is safe. So 50% of facet was drilled and the foramen was enlarged, and the patient is completely pain free, with a pain score of 0 immediate post-op, and without any deficits. This was the first case of cervical spine endoscopy which was done in Kerala. So we were lucky to do the first case of cervical endoscopy. So to summarize, to end, I'll say that in open surgery, what we do is a carpet bombing. We remove everything. We damage the muscles, we damage the bone, which are not pathologic. Whereas in endoscopy, it's a targeted, specific. We finish off only the culprit. We are not damaging any innocent bystanders. Thank you.
Yes, for the excellent presentation. For the full endoscopy discussion, one topic for discussion.
Neuropathic pain, but in most cases, neuropathic pain, when the pain is severe, even after you do the procedure, such as in catheter syndrome and all, even if you do the decompression, which is the pain might persist. So, you have experience with that, because the optimal result in what pain
You should-
management
Yes,
not be achieved even after decompression.
that happens especially in open surgery. Open surgery, we see that because the visibility, we are not sure. I mean, when we do open surgery, we are not sure of the decompression. Whether, especially in a lateral disc, when you do a micro discectomy and we remove the disc, we don't know whether in that foraminal area, whatever compression is there, it is usually not relieved completely. And most of the times, even in immediate posterior, there will be some, this compression has been there on the nerve root for so long. So they will have some dysesthesia post-operatively for some time. But usually, if you have done a sufficient decompression, then the pain gets relieved, in the follow-up. It's more than pain, especially after this endoscopy. Usually, what patients say is that post-operatively pain is relieved, but they have new numbness. So they have in the same area they have severe numbness. But actually, what happens is numbness was there even before. But when the patient had severe pain, patient was not able to appreciate the numbness. But once the pain is gone, this numbness is the one which they complain of, and that usually relieves within a month or two. complications as with the, open surgery, nerve, neural damage, that is the most significant damage. But here we have very good visibility. So complication rate is lesser as compared to open surgery. But the one problem is, as I said, if patient is completely relieved of pain post-operatively and they do not take sufficient rest. And what is said as papers have suggested that the recurrence rate following endoscopic surgery is little bit more than the open surgery, because immediate post-op, because the annular tear heals, patients start mobilizing. Whereas in the open surgery, patient have back pain for several months because of the muscle spasm. So that's why they do not do their routine work or activities. So when they go back to activity before the healing of the annulus, chance of recurrence is more.
So it means patient selection would be vital, very vital.
Patients, yeah, obviously patient selection for as such for surgery is important, but with endoscopy we can tackle the discs which are not amenable with open surgery as well. Sir.
Appreciate your talk. Thinking about it, what happens that this phase once this is removed, whether that causes any with the problem?
That can happen because when the disc space is reduced, all the weight is on the facet. So facet joint arthropathy and future facetal instability can happen. That can happen with any disc, open surgery as well. That is why, as I said, we remove the only pathologic disc. We do not go in and remove the whole disc. Even though it has been shown that if you remove the whole disc, then the chance of recurrence is very less. When you remove only the partial disc, when you remove only the herniated disc, the chance of recurrence is a little bit more. But when you remove the whole disc, the chance of further progression of the facet joint arthropathy and instability is much more going forward, maybe after a few years. So that is why over the last 10 to 15 years, complete disc is not removed. Even in the open microdiscectomy as well, we remove only the pathologic disc. We do not go in and remove the whole disc. There is. There are new, replacement, artificial disc is available. No. It has to be open. As I said, just like the cage placement, we have to prepare that. We have removed all the disc material and then place this disc, artificial disc. No, it can also be done as with the endoscopically. It can be done. It can be done endoscopically. Just as I said, I showed you the cage. Instead of cage, we put the artificial disc. Artificial disc costs around 1.5 lakhs. Medtronic. Steel, sir. Steel.
Same thing is what we use.
Yes, sir. Yes, sir.
Keep for the placement of the is in the
needle insertion is the most important thing. Siam and needle insertion, if you are in the proper place in the needle, as I said, especially with the transforaminal, if you place the needle properly, you can come out within half an hour. So if you are somewhere else, then you have to adjust the scope and it takes a long time. Another thing is bleeding. If there is a significant epidural bleed, then also it takes a lot of time with the endoscopy. Whereas in open surgery, we can finish it off in 45 minutes, discectomy. I have had cases where I have taken even 2.5 hours sometimes, because when there is epidural bleed. Sir? Yeah, you can do that. No, even the open disc, microdisc, we will do it alone.
There aren't any more questions. We wind up the CME session as of now. Thank you very much, Dr. Mahesh. Your genuine interest in spine surgery has been well exemplified by this presentation.